Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hello, everyone, and welcome to the Chest Journal podcast. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and today I have the pleasure of talking with Dr. Shaurya Taran about his study on low-tidal volume ventilation and mortality in patients with acute brain injury. Welcome, Dr. Taran, and thank you so much for being here.
Thank you, Alice. It's a pleasure to be here. Thanks for the invite to do this podcast with you.
I'm so glad you're here. So tell our listeners a little bit about your day-to-day work.
Yeah, so I'm an intensivist at the University of Toronto, did my training in general critical care, and then went on to do an additional year of subspecialty training in neurocritical care. And following that, did a PhD in clinical epidemiology, which I'm just in the process of finishing up. My day-to-day involves attending in a mixed medical, surgical, neurosurgical ICU at the University of Toronto in Toronto, Canada, which is where I'm currently based.
That's amazing. So tell us about your inspiration in your day-to-day work to look into low tidal volumes in the neurocritically ill, and a little bit of the background of your study.
Yeah, so I'd say the inspiration is twofold. Again, I see these patients in my clinical setting on a day-to-day basis. That ideal tidal volumes to ventilate these patients with are not clear. It often stimulates some very interesting discussions on rounds in terms of what tidal volume is best. But it's also, I guess, the question for the study arose in the context of how we ventilate our patients more generally. So we know that 1 in 5 patients worldwide receive mechanical ventilation, do so because of an acute neurologic condition. These conditions include traumatic brain injury, ischemic stroke, intracranial hemorrhage, subarachnoid hemorrhage. And again, like I said, the best method for ventilating these patients is not clear. A lot of our clinicians will probably face the conundrum of how to choose the right tidal volume in this population. And the reason it's not clear is because on the one hand, we have great evidence from trials done in the ARDS population that suggests that tidal volumes close to 4 to 8 mils per kilo predicted body weight, or close to 6 mils per kilo, reduce ventilator morbidity and mortality. Many of your listeners will be familiar with the ARMA trial published in the New England Journal in 2000, which was really the landmark trial that showed that low tidal volume ventilation was, a life-saving intervention to do if you had ARDS. But since that trial, low tidal volume ventilation has also been shown to improve outcomes in lots of other populations that don't have ARDS, and in fact might even lead to less ARDS when you use it as your kind of upfront ventilatory strategy in patients with broad categories of respiratory failure. So we have pretty good evidence that it's a good thing for most patients, and so why would patients with acute brain injuries be any different? And I think it relates in part to the impact of low tidal volume ventilation on carbon dioxide, right? So as your tidal volumes come down, your carbon dioxide levels can go up. Mm-hmm. And in patients without brain injuries, standard ARDS, we might not worry about that carbon dioxide going up as long as there isn't a significant concomitant acidemia. But if you've got brain injury, then that elevation in CO2 and that acidemia can actually increase your intracranial pressure. And that might not be a great thing for patients with brain injuries in whom you might already be worried about the intracranial pressure at baseline. So how do we balance the benefits of low tidal volume ventilation when on the one hand we have great evidence that it works for patients with ARDS and without ARDS, with the kind of the risks, if you will, of applying this otherwise good intervention in patients with brain injury because of the things it can potentially do to ICP? And that's the crux of what we were trying to answer in this paper.
Oh, I love that. And another thing also that caught my attention, and it always catches my attention when I take care of neurocritically ill patients, is like it's so heterogeneous, right? Like the population itself, the reason for respiratory failure is so heterogeneous also.
Yeah, that's a great point, right? We know that in patients with acute brain injuries, the reasons for these patients requiring ventilation may not be the same if we think about it for compared to other populations, right? We typically intubate these patients for decreased level of consciousness, loss of airway protective reflexes. We're trying to prevent the kind of future aspiration that these patients are at higher risk for. And it's not really for respiratory failure per se in the majority of patients up front. Now, of course, things like ARDS, neurogenic pulmonary edema, and so forth can develop afterwards, and respiratory complications are quite high in this cohort, but it's not often the primary reason for intubating these patients.
Yeah, exactly. That was one of the things that really got me thinking when I was reading your paper to prepare for today's talk. So on that segue, let's talk a little bit about the methods you use in your cohort and why you decided to do a secondary analysis of the prospective observational study, extubation in neurocritical patients, and association with outcomes.
So Alice, as you mentioned, this was a secondary analysis of this other study called ENEO, which was published a few years ago in Intensive Care Medicine. The reason we chose this particular cohort is that it gave us time-varying parameters of interest, including our main exposure, which was tidal volume. And so rather than dealing with just data at baseline collected at ICU admission and having an outcome that you could do a fairly simple regression model to look into, we chose this particular data set because the data that was available to us was relatively granular and encompassed a period of high acuity in the ICU, which was the first week of invasive mechanical ventilation. So that was the particular appeal of using this particular data set, ENEO. The parent study was done in 73 ICUs across 18 countries as well. So it was a fairly large data set that was quite broadly representative of how these patients are ventilated across countries worldwide, which is also another appeal, right? You're not just dealing with local data from one or a handful of ICUs. This really speaks to how we ventilate patients with brain injuries in large contemporary global settings, which was, again, a huge appeal of using the particular data set.
Yeah, that's awesome. And so tell us a little bit about your results.
The study itself was done, maybe just to talk through how we design the models. It was done through a modeling strategy that used the time varying data that ENEO collected. And so we designed the statistics to reflect the time varying nature of the data, and you used a modeling strategy called marginal structure models. So these allow us to estimate the causal effect of receiving an intervention over time compared to never receiving it. So in our case, the intervention was low tidal volume ventilation, which we defined as less than or equal to 8 mils per kilo predicted body weight of tidal volume over the first 7 days of mechanical ventilation. So in ENEO, they collected data on mechanical ventilation and other confounders on days 1, 3, and 7. So we didn't have perfect day-to-day data, but we did have it over at least 3 time points over the first week of ventilation. Wow. So we used marginal structure models to evaluate the causal effect of receiving low tidal volume ventilation over that first 7 days compared to receiving more than 8 mils per kilo predicted body weight, which was the comparator group of patients. So for listeners that may not be familiar with marginal structure models, because this is a somewhat more advanced causal inference technique.
Very unique, yeah.
Yeah, essentially the appeal of it is it allows you to determine the impact of a time-varying treatment. So something that's changing over time, that's dynamic, that doesn't carry the same value day to day in this case, on an outcome of interest. And in our case, the time-varying treatment was tidal volume. And again, this is crucial. It asks the question, what would outcomes be if everyone received the intervention that you were interested in, which in our case was low tidal volume ventilation, less than or equal to 8 mils per kilo, compared to no one received the intervention of interest?
Ooh,
so it's doing this by using all of the data that you choose to give it. In this case, we gave it baseline characteristics and time varying covariates, and it creates 2 pseudo populations of patients. So it uses the data of real patients within the data set, but it creates these pseudo populations of patients that are not real patients. And it assigns these patients to pseudo populations of always treated versus never treated. And the difference that this model gives you at the end, which in our case was a difference in mortality, reflects the difference in the treatment of interest on your outcome of interest. So we're using the time varying data to create patients to always treated versus never treated groups, and then calculating the difference between those two groups to get what we call the marginal risk difference. So this is a population level effect of what does tidal volume less than or equal to 8 mils per kilo do in your broad group of patients with acute brain injuries compared to if they never got that intervention. So that's just a little segue into how these models work. And the results, again, when we applied this class of models to the estimation of ICU mortality, we found that there was a pretty significant difference in favor of using low tidal volume ventilation in terms of mortality. So the marginal hazard ratio was significantly in favor of using low tidal volume ventilation. I think the point estimate was 0.54 with a confidence interval that did not cross 1, suggesting at least in that frequentist framework a significantly protective effect of low tidal volume ventilation.
For the listeners who have the paper in front of you, this is figure 3. Please keep talking.
Perfect. Yes. So figure 3 will summarize most of the important data in the analysis. And as figure 3 will also show, we looked at this analysis in subgroups of patients that were defined by what we thought would be important effect modifiers, like your baseline Glasgow Coma score at admission, the effect in patients who are older versus younger, the effect in patients who might have traumatic brain injury as their etiology for ventilation versus any other etiology. And of course, what would be the effect based on how bad the lungs were at the start of ventilation, which we quantified with the P to F ratio at baseline. And for the listeners that have figure 3 in front of them, you'll see that the point estimates, both for the main analysis and across all of the additional analyses, seem to be in the direction of low tidal volume ventilation being protective. Now, subgroups are, at least in some of these cases, are smaller. So some of these confidence intervals do cross the one line. But that probably just reflects imprecision related to the smaller subgroup sample. What's interesting to see is that the point estimates consistently lie towards low tidal volume ventilation being protective.
Yeah. And was there anything in the results that surprised you?
Yeah, so there were a few sensitivity analyses that we carried out just to test the robustness of these findings under different assumptions. So the main analysis used a threshold of 8 mils per kilo predicted body weight to dichotomize low tidal volume ventilation. And in a series of sensitivity analyses, we looked at lower thresholds to define low tidal volume ventilation, including 7.5 mils per kilo, 7 mils per kilo, 6.5 mils per kilo, and 6 mils per kilo. So we used 4 additional cut points to define the intervention versus comparator groups. And I'd say what surprised me is that, as you can see, and this is probably best reflected in table 2 for the listeners that have the paper in front of them, the point estimate as your threshold is getting lower and lower seems to go increasingly towards the null and then crosses the null line, such that when you're at less than or equal to 6 mils per kilo predicted body weight, your hazard ratio, at least on the point estimate side, is 1.12. Very large confidence interval that goes from 0.39 to 3.19. But it was interesting to see that, as we became more stringent about the tidal volume threshold to define low tidal volume ventilation, we lost that statistically significant finding that we'd seen in the main analysis and subgroup analyses, which made a few of us in the author group wonder about kind of where is the best kind of place to dichotomize, this low tidal volume threshold in patients with brain injuries.
Yeah. Didn't also the fact that driving pressures and plateau pressures were pretty similar? Because I was surprised about that. I would think that the patients who received higher tidal volumes will have significantly higher both of those pressures.
Yeah, no, it's a good point, and I think reflects the fact that this cohort of patients in general probably had pretty good lung mechanics at baseline, which again speaks to why, why these patients are intubated in the first place. It's not often for respiratory complications. It's because of the primary brain injury and the fact that they need, all of the sedation plus or minus paralytics and so forth to manage intracranial pressures and so forth, and not really the respiratory characteristics that drive the reason for them being ventilated in the first place. To your point about the driving pressures and the plateaus being low, with this marginal structure model approach that assigns these patients to different groups, we don't know what the driving pressures and the plateaus would be within those two pseudo populations anymore, because what we're stratifying by, at least statistically within the model, is the tidal volume. So we can be guaranteed about what the tidal volume is, and in both groups, it's going to be less than or equal to 8 versus more than 8 because that's what we set it at. But the other parameters that are also of interest clinically, like PEEP and driving pressure and so forth, are not known at that group level in a marginal structure model.
Oh, yeah. So bringing everything to bedside, based on your findings, what are your clinical recommendations for our colleagues who take care of neurocritically patients?
Yeah. I mean, the clinical message here, I think, is that ventilating patients with low tidal volume ventilation close to 8 mils per kilo is probably safe and might improve outcomes, at least on the basis of this observational study with all of its limitations in patients with brain injuries. The impact of going lower and lower, close to 6 mils per kilo and so forth, remains unclear, at least on the basis of this study. You start to lose the potentially beneficial effect. It becomes not statistically significant. And when we think about this study, in addition to other studies that have been published, including one randomized trial, which showed that 6 mils per kilo potentially led to worse outcomes in patients with brain injury compared to greater than 8 mils per kilo, then it makes me, at least clinically, get cautious about lowering it too low, unless there are other reasons like ARDS and we're trying to minimize driving pressure and so forth, at least in patients with brain injury. So my take home point here is that ventilation with tidal volumes close to 8 mils per kilo is probably safe and might improve outcomes. But when you go lower and lower, and exactly where that kind of risk benefit threshold changes is unclear, but when you go lower, close to maybe 6 mils per kilo, it might start to go more on the side of harm.
And that makes sense from what we were talking about initially, right? Maybe is the permissive hypercapnia that we are okay with in ARDS, but again, in neurocritically ill patients, the reason for intubation, the reason for respiratory failure might be a little different than primary lung injury, right?
Exactly, yeah. So it could reflect that the CO2 is going up as your tidal volumes are coming down. We did not specifically look at how CO2s were changing as we were bringing the tidal volume threshold down. Again, the marginal structure model doesn't really allow you to tease out how those other confounders are changing as your exposure is changing. So it could reflect mechanistically the CO2 going up as your tidal volume is going down. It might reflect other things, right? As your tidal volume is coming down, you're in most cases increasing the respiratory rate to maintain your minute ventilation. And in brain injury patients, also trying to keep your CO2 within normal. What implications does that have to things like mechanical power and other surrogates of ventilator-induced lung injury? We don't know, right? So there are mechanistically a few different hypotheses we could put forward to suggest why this beneficial effect is not being seen at lower tidal volumes. But I think that particular question is not answered by this study, but I think it's a fruitful one for future studies.
Yeah. I love all of this. Do you have like a last, maybe a couple pearls of wisdom for our listeners in terms of ventilating neurocritically ill patients? So like 2 pearls.
2 pearls. Okay. Yeah. So I think that pearl number 1, maybe unrelated a little bit to this study, but when I'm, asked to give talks on mechanical ventilation, brain injury, this one always comes up. So Pearl number one, I would say, don't hesitate to think about lung protective ventilation as more than just tidal volume reduction, right? There's other things that come with that, including optimization of positive end expiratory pressure, PEEP, right? And so historically, there's been a very kind of overall significant reluctance to use high PEEP in patients with brain injuries, even if they might need it for things like respiratory complications, ARDS. And part of that concern reflects the impact of PEEP on intracranial pressure. And historically, there was this blanket concern that PEEP is always bad because, at least in this population, because it increases intracranial pressure. The thought was it does that, again, through attenuating your jugular venous inflow by increasing your intrathoracic pressure. But in fact, the impacts of PEEP are quite unpredictable in patients with brain injuries. Some people will indeed have high ICP as you increase the PEEP. In other patients, the PEEP may not do anything to the intracranial pressure. And in some patients, increasing PEEP may actually decrease your intracranial pressure. And there are surrogates that you can use at the bedside to decide how PEEP is going to impact ICP. And some of these are better than others. But my first pro would be don't hesitate to cautiously optimize PEEP and try different thresholds, and maybe do away with this historic notion that increasing PEEP is always bad for intracranial pressure. That's not the case.
I love that.
And PEEP is fantastic, right? It can help us get more lung protective without ever having to do anything to the tidal volume, right? Yeah. And sometimes it can help us lower the tidal volume further if we're judicious and careful about how we optimize PEEP to minimize the overdistension concern, but also kind of promote the alveolar recruitment or to prevent the derecruitment. So that's pearl number one. Pearl number two, I would say, is these are dynamic treatment regimes. So what works well on day one may not be the best thing to do on day two and may not be the best thing to do on day three, right? So
I love that. Go to bedside.
Yeah, go to bedside and continuously reassess the patients. As we said by starting off this podcast, these patients are not often intubated primarily because of respiratory issues, but those respiratory complications can develop, right? When we think about the time course of ARDS development, right? It's very, very common in this population. Neurogenic pulmonary edema, if you're dealing with subarachnoid hemorrhage patients, can be quite early. Aspirations can indeed happen, and the implications to lung mechanics may not be right up front, but indeed you could see them a few days down the road. So continuously reassess what's good for your patients. And if these patients do need lung protective settings down the road because of things like neurogenic pulmonary edema, ARDS, aspiration, and so forth, then don't hesitate to apply them. And if there's concern that they could impact your intracranial pressure, then that might be a thing to look into with your neurosurgery colleagues in terms of, do these patients need invasive monitors to help make sure that what we're doing for the lungs isn't having adverse implications for the brain with respect to ICP. So yeah, dynamic patients, indeed, there can be ICP effects if you're not sure. It's always worth having a conversation about whether an invasive probe or an EVD is necessary in these patients.
I love that. So dynamic, go to bedside, talk to your neurosurgeon colleagues, and don't be afraid of PEEP, but use it judiciously.
Yeah, don't be afraid to optimize it. And again, if there's any concern that it could impact intracranial pressure, then it should start conversations about whether we need an invasive monitor. Of course, these patients should have other, indications for the monitor. It's not just to titrate ventilatory settings, but often the two will travel together, right? Severe brain injuries, bad lung mechanics. And they might just need it for the severe brain injury side of things. And then you can use that information to optimize lung mechanics.
I absolutely love that. I loved talking to you. You're awesome. And I obviously thought your paper was amazing. And to our listeners, I just had the pleasure of talking to Dr. Shaurya Taran about his paper that is going to come out this month in the Chest Journal, Low-Tidal-Volume Ventilation and Mortality in Patients with Acute Brain Injury. Dr. Taran, thank you so much for joining me this morning, and I really appreciate you being here, and I absolutely love your work.
Thank you. Thanks so much, Alice. A pleasure to be here, and thanks again for the invite.